Hi there, my name is Josh and I have with me Jen and JP, who you can see on the slide here. We spoke in this session at the Australian Pain Society conference in Darwin, and there were lots and lots of questions in the Q&A and we didn't get to 9 of them. And so we're going to do that now and just post it here online if anyone is interested in watching. But let's continue the Q&A now. So the first question here is for JP. Can you offer any insights into what system changes might be needed to ensure that CFT, cognitive functional therapy, for anyone new, is implemented as intended, fidelity, and in a sustainable manner in the Australian health system?
I think that's a great question. And I think there's 2 levels that we can do things to support the implementation of CFT. So there'll be a local level and a system level. So at a local level, that's our job. And what we're doing is developing an educational platform that will provide clinicians with an opportunity to go through the tier training program and, at some stage reach competence in CFT, and the accreditation to deliver CFT will be through this accreditation process. So it'll be competence-based training, and that will be still at an individual level. But if we want to upscale this, and that's one of the big issues, we are creating like a train the trainer model. So people that have gone through the tier training program, then go through a training program to become trainers, and then they become like local champions in their communities, and they can train other clinicians through the same process. And we feel that what needs to happen, and that's one of the things that we learned through the RESTORE trial, is that over time clinicians can drift from their training. So what we think is necessary is that on every 2 years, clinicians need to kind of resit an assessment of competence to make sure that they're delivering the care as per their training. So that will promote fidelity of delivery of CFT. And at a systems level, accessibility to this level, this sort of care is an issue. And we are doing our part in trying to build a community of clinicians that can deliver this care. But then we probably need funding changes that support starting big fund low value care, and then they provide funding to higher value care. And, in more around, for instance, we have the care health plan that provides 5 sessions for allied health practitioners. And that could be distributed across exercise physiologists, podiatrists, physio. How about we fund 8 to 10 sessions with a certified clinician, so people can have access to this care and be supported by Medicare. And probably the private health funds also supporting the delivery of this higher value care for their patients. So I think these are some of the initiatives that can occur. Some of them depend on us, and we'll definitely be pushing for changes at a policy level. But we need some help from the funders as well to support this journey.
Cool. Fascinating. All right. The second question, it's for me. Josh, how do we spread similar pain subjects across other institutions and different discipline courses? So yeah, my talk was about the UTS Master of Physiotherapy course and the pain subject that I coordinate, and we talked about that. And I guess the question here is saying, can we replicate that in other places? There are a couple of other universities kind of globally that I'm aware of where the whole subject is devoted to pain. There's other subjects around the world that map the IASP physio curriculum across several subjects and kind of across different courses. So there's different ways of doing it. And I don't know if one's better than the other. I'm just wrapping up one today, actually, the subject. And so this last kind of 6 months, I think there is something valuable and probably similar to what JP was just saying about like being fully immersed in one subject at a time, rather than it being like scattered throughout and potentially missed. So how do we spread it? I guess we make the IASP curriculum more aware in people's minds, if people can stay up to date with the evidence. But And also I guess building online freely available resources that kind of get shared across institutions. That is tricky, I think, with IP, and there's some barriers there, but I think that it's all the Payne lecturers that I know are all wonderful people. So I don't think it's an impossible barrier to overcome. All right, the third question is for Jen. So Jen, you can do a quick intro for yourself as well, but it says you talked of barriers to care from clinicians and possibly flip it. How? We might need help with that question too.
Might need some context. I think this question was in regards to work we're doing at the moment in pediatric chronic pain, where we sort of asked health professionals about barriers and facilitators to providing care for kids with chronic pain. And what the sort of research that we found is that for some of our categories, they were listed as a barrier and a facilitator, or they could have been more heavily listed as a barrier compared to a facilitator. And I think when we're sort of talking about flipping it, an example of this is, one of our themes that parents are influential in care, that was equally listed as a barrier and a facilitator. And I suppose it's starting the conversation of, particularly in pediatrics, if we know that parents are always going to be involved in care, and we know that they can be both a barrier and a facilitator, is there a way we can sort of change the narrative or view it with a different lens to go, are there things I can put in place to sort of flip that barrier and help our parents to be a facilitator, for example? So maybe encouraging people to think about flipping the script or changing their lens to maybe start thinking about some of these factors that are maybe always present. Are there ways that we can change it from a barrier to a facilitator in care?
Yeah, I think even just being aware that some things are considered a barrier by some and a facilitator by another is kind of interesting and maybe a good starting point. So cool. Let's keep going. So number 4, it says, Josh, the students filled in questionnaires before and after the course showed an improvement in their understanding. Were they simply flattering their tutors? Possibly. So we try as much as we can to do this like ethically in a good way where they're not coerced or pressured. There's de-identified, all of those kind of approaches, but I suppose none of them are perfect. I think the first questionnaire, the very first one in the course is on orientation day, and I reckon there would be a likelihood for people to overly try and respond in a positive way. So we've actually got, like, what I presented at APS was the first semester, but we've collected data at 1 year and at 2 years. And I think looking at more time points should hopefully help us answer that question. But it's a really good one. And I think even if they are flattering their tutors, I think the fact that if questions are changing, what is probably needed is qualitative work to ask them about, hey, why did you change your answer to that particular question? And that would help us unpack and unravel whether or not they are just flattering their tutors. But yeah, it's a good question. All right, number 5, back to JP. In the Restore trial, what was involved in usual care and how did it differ between the CFT intervention?
Right. So the usual care, basically people had access to whatever they had access to. So there was no restriction. They could keep going to the GP, physio, chiro, osteo. They could have surgery, injections, whatever. And so we didn't restrict what they had access to. We just monitored that through their Medicare. In terms of the difference to CFT, I think that it's probably quite a big difference in terms of what people can get. And that kind of reflects what physiotherapy is these days. And, it can range from electrotherapy and dry needling, massage therapy towards a psychologically informed physio practice. And we're sitting on this end of, delivering guideline-based recommendations. So CFT is a very person-centered approach, and that aims to explicitly target multiple factors that are contributing to the person's pain experience. So not only we identify them, and we explicitly target them. And perhaps the question is alluding to the difference between the CFT groups, where we had 2 CFT groups. One of them was CFT, only, and the other one was CFT with the use of movement sensors biofeedback. So basically, in both groups, patients were wearing sensors in their back, and data was being collected. However, in the CFT plus biofeedback, the clinicians had access to that data that could inform their decisions about care, and they could set up, biofeedback at home. So, the patient could be kind of reminded to modify their posture, for instance. But the key is that using the sensors or not, it didn't make a difference. Like the sensors didn't add any value to CFT because the results demonstrate that both groups achieved the same outcome, which were significantly and meaningfully better than the usual care group.
Hey, JP, so in the usual care group though, did you actually track like how many people got surgery and how many people got physio? Like, do you have that data as well?
We have data in the expenses, and we may have finite data on what it actually done, but we haven't reported that specifically.
Yeah, it's interesting because I'd imagine that would confound the results potentially, but maybe in CFT's favor. But interesting.
Yeah, I think one of the criticisms that being raised is around because a lot of people had given up on care, and that really reflects what we see, at least in my clinical practice. We see a lot of people that just gave up. And maybe they come back because they come back through an insurer, or they come back because they've been, they're seeking a third or fourth opinion. But in general, a lot of people have given up on care, and that reflects what care that is being provided in general.
Yeah, that's so interesting. Number 6, Josh, what's the name of the program to assess the students on video? The last 5 minutes of the appointment. This is called VIEPL, VIEPLE. Our uni just has a subscription with this service, so I don't know if there's others out there, but it's basically a job application, like interviewing software. And the idea is that you could conduct an interview and they can do it at a time that suits them. So for international time zones and things like that. So a question pops up, their camera just records, and then it cuts out automatically as well. And you can allow resets and all sorts of different little parameters on it, which is nice. So for the assessment, I just set it up. It happened today, as I said earlier. And so they just times out at the 5-minute mark. So they already knew the case from earlier in semester. Then it's like the patient has asked you this question, how will you respond? And then the video just starts recording. So it is really interesting. And I really like it as an assessment kind of way of, like, for a student, allows them to do it at a time that's comfortable, but it's pretty close to replicating the pressure of a telehealth appointment where you don't get multiple takes. So we encourage students, if they were flustered, to take a breath and have another go, those kinds of things, rather than quitting out and making the recording exactly perfectly what they wanted. Question 7. JP, thanks. I'm sure you face this question quite a lot. When you say that you didn't allow manual therapy, does this mean any form of hands-on or only specific things like joint mobs?
Great question. So yes, we restricted in terms of any techniques of manual therapy. So massaging, joint mobilization, any of the things like dry needling, they were not allowed to do any of that. But hands-on feedback is a massive part of what CFT is. So touch is so important, but the way we use it to validate the person's experience. We use to guide as they are moving. We use to provide them feedback in terms of how tense their body is or how relaxed their body is now. We use as part of the assessment to identify, touch sensitivity. We use to support them and provide guidance during the exposure aspect of the management. So it's highly valid and important tool that we use, but we don't use it to promote the use of specific techniques and to promote dependency on the clinician.
I personally love that reframe of what touch could look like and be defined. It's really interesting. And But I know there's probably people watching this who would strongly disagree. And so it'll be interesting. Hopefully, by doing this recording, we're generating some useful conversations here. Question 8, Josh, is the course an online learning course considering the online assessments, or is it face-to-face? No, the UTS physiotherapy course is all face-to-face. I mean, most lectures and things are they seem to be moving towards this online or maybe hybrid kind of approach, but definitely all the workshops, we call them, or tutorials, are all face-to-face for every subject. It's very practical and kind of hands-on in the way that JP is describing. Last question is, hi JP, how do you source patients for the trainees to learn on?
We put a call out through, our referral GP networks and through universities and local clinics and word of mouth. So anyone that was interested in a second opinion, that was struggling and wanted to be seen, they were invited to be seen by the clinicians during the training program. So they're all patients. We saw about 80 or 88 patients in the training process, and they're all very, like a diverse range of presentations, but the majority of them highly disabled.
Okay, yeah. Great. Well, that's the last question in the Q&A. So thanks for watching, everyone. Maybe we should go around, give everyone one more last chance to say something. Let's put links to the papers that we've talked about that are related to our talks. But yeah, anything else? Jen, do you want to start?
No, you put me on the spot there, Josh. A surprise question at the end. I think for me, it's watch this space. We're sort of building a picture of what some of this work looks like when we're working with kids, particularly in the community, and how we support community clinicians working with kids that are maybe struggling but haven't quite gotten to that tertiary referral point yet. So watch this space, and hopefully we'll have some interesting work coming out soon.
Great. And JP, anything else?
Yeah, one thing that I mentioned in the presentation that I think is worth reminding people here is that as a consequence of Restore and this idea of upscaling and upskilling clinicians, we are engaging on and developing a social enterprise, which has as a core mission to provide equitable access to education to all clinicians, including people in low-income countries. So that we're in the process of developing that. We are hoping to launch that in the second semester of this year. And there will be, access to the whole training program, but also free sections of resources for patients and clinicians. And if you want more details and want to register your interest, as well as looking at details of the Restore trial paper, you can look at restorebackpain.com and you'll find all the information there.
Excellent. Well, thanks again, guys. We'll post some notes in the comments or the little thing below. And yeah, we look forward to hearing what people think.
Josh, do you have anything to add?
Oh, not really. I
Good
mean,
point, Jen.
this isn't my main line of research, but it's like kind of my main part of my teaching job. And so I think it's a privilege that I can kind of mix the worlds. And yeah, my main research in pediatric pain and working with wonderful people like you, Jen, is kind of heading down that path of going like preventative education and thinking about how can we do some of these things of upskilling, but like in a preventative space, like for kids going to school. So anyone watching who wants to collaborate on that, that'd be brilliant. But yeah, thanks again for watching, guys. And thank you, Jen and JP, for joining. We'll see what happens. It's a bit of an experiment, right? Thank you.
Thank you so much.
Thanks, Josh.